Welcome back to the Psychiatry Boot Camp podcast. Today we're talking about case formulation. This is a skill set that takes time and practice to develop. I think probably until the day we stop practicing psychiatry, we'll be working to improve our formulations. And in fact, this is certainly true because new scientific evidence emerges and our culture changes, and these realities need to be reflected in our formulation. So in this episode, we're going to give you the scaffolding on which to place your expertise. You'll need to lean on your therapeutic alliance and your history-taking skills in order to get the information that you need from the patient. But then you also need to have extensive didactic knowledge of the different biological, psychological, social, developmental, and cultural factors in order to have a robust formulation. Now, Rome was not built in a day. Some of the information here, attachment styles for example, represents content that you may never have encountered before in your medical training. I know that I have a long way to go in gaining knowledge and honing my formulations, so be compassionate to yourself and remember that this takes practice, 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 and you'll get better every formulation that you do. Today's expert is my program director here at Creighton, Dr. Jyotsna Ranga. And Dr. Ranga, I'll ask you to introduce yourself to our audience.
Hello, my name is Jyotsna Ranga, and I'm a child and adolescent psychiatrist, currently working at Creighton as the program director for both the residency as well as the Child Adolescent Psychiatry Fellowship. It's a privilege and an honor to be here, Mark.
And so you're here to talk with us about case formulation, a topic which you've taught me several times at this point in my career. And I think this is something that is, for the most part, really unique to psychiatry of all medical specialties. And because it's so unique, it's not really something that's covered in depth in medical school. So I think it can feel really daunting to take the human condition and narrow it down into a couple of paragraphs. And I guess my question is that our goal? What really is our goal when we're going into a case formulation?
Agree with you, Mark. A human being is such a complex tapestry, right? A collage with so many pieces. I think it may be never fully possible to understand another human being fully. I would say that the goal is a humble attempt to understand the patient's story using multiple dimensions, including a biopsychosocial lens, a developmental lens, a cultural lens, and family system lens. Each patient is so exquisitely unique, and we can strive to understand them as holistically as we can so that then we can tailor our treatment interventions to best fit with their distinctive situations. And whatever that may be, that can be pharmacotherapy, a specific type of therapy, etc. And when we learn how to document this succinctly, that gives us a chance to hand off this patient-centered narrative that we have created to the next provider who may then be able to start off with a deeper understanding of this unique person's human condition.
So in thinking about, our assessment and plan in psychiatry, I think formulation and diagnosis are what jump out in the assessment. So what is the difference between a case formulation and a diagnosis?
So the diagnosis is a list of criteria. The formulation is much more comprehensive than a diagnosis. So, for example, the diagnosis may not fully explain how the illness unfolded in this patient's life and the impact that it has had on this patient. The diagnosis, however, is more of a list of criteria, which gives us an idea of what disease the patient is struggling with, and it standardizes our understanding in the field. So, in other words, formulation is more of the story. It's patient-centered. It may have an etiological perspective, a descriptive, a prognostic element. And if we're able to do this collaboratively with the patient, it gives them an understanding of why they are at this point in their life and some words to describe that and a summary to internalize, to give themselves future goals.
I think there's definitely value in going through the formulation with your patient to help give them some more insight into why they're kind of going through what they're going through. And I think especially as a learner, I like the formulation a lot because it gives me a chance after I've had this really intense emotional experience, this encounter with the patient, to kind of sit back and think from 50,000 feet about what am I really seeing and what can I do to best help this patient. One of the ways that I think about this is that formulation tells us how a patient is different from other patients. What is really unique about this patient's experience. Whereas diagnosis, we talk a lot in episode 1 about everything that diagnosis is not. But what diagnosis is it tells us how patients are like other patients, which of course we need in order to develop our psychiatric evidence base and to make evidence-based treatment approaches to our patients.
Agree, Mark.
Okay, so let's say we've interviewed the patient, as Dr. Ramel walked us through. We've gotten the HPI, the presenting problem. We've done the full psychiatric review of systems. We've gotten our past psychiatric history, past medical history, family history, social history, an enormous amount of information. How do you go about organizing all of this information into a case formulation?
So, as we've referenced, it's sort of like coming up with a painting. And, I'll share with you the recipe or the structure that I use. For trainees, this may seem to be a mysterious process. So, therefore, in the training world, providing a template or a structure upon which they can build is so important. So, potentially, two ways of structuring formulation could be using the biopsychosocial template that George Engel brought forth in about 1977, with the focus on patient-centered care. And adding to that could be developmental lens, cultural lens, and a family systems perspective. So that's one way potentially to structure a template that residents can use. The other way is to use the 5 Ps, which is well known in our field. And the 5 Ps stand for predisposing factors, precipitating factors, presenting factors, perpetuating factors, and prognostic factors. So providing them a template with these tenets helps the resident put their thoughts together and construct that patient narrative.
Now, are these two distinct ways to do this? Or when you're doing it, are you sort of combining the two, the biopsychosocial model and the 5 Ps?
I think you can do it either way. I think when I formulate, I use both aspects so that I can get a more in-depth 3D understanding of what my patient story is.
Right. So when you talk about the 5 Ps, you can imagine where each of the 5 Ps might have elements of the bio, psycho, and social
Exactly.
pieces. So there's
Exactly.
biological, psychological, social predisposing factors, precipitating, presenting, perpetuating, prognostic, etc.
Exactly.
Okay, that makes sense to me. So then let's dive into this sort of biopsychosocial model, or I think here at Creighton, sometimes we'll talk about the biopsychosocial spiritual model, and I think that'll come through hopefully throughout the course of this podcast. Starting with the biological piece, what are some important things to consider when we're thinking about the biological piece of the formulation?
So, important things to consider would be the genetics. So, the family history of this patient, any medical illness the patient may have that may be contributing to the present symptomatology, any brain injury, insult, medication use, substance exposure use, and also temperament. What is the innate person like? Slow to warm up or easy or difficult? All of this contributes to the biological predisposition.
And what about our psychological factors? So biopsycho, what are we including here?
So, in the psychological factors, sometimes trainees sort of blend that with sort of the social and clump that into psychosocial. I want to delineate a little bit between the two. So, in psychological factors, what comes to mind is the quality of attachment that the patient has experienced that connects to sort of that internal working model or the dance that the patient creates with everybody in their life. And that relates to, as we grow older, to social competence, emotional regulation. So attachment is so important and has broad ramifications. One's sense of self, self-worth, security, all of that comes back to that quality of attachment. Then you can think about cognitive schema. What is the lens through which this patient is viewing the world? What is the coloring? What are those distortions? The other thing that I think we consider when we're thinking about psychological factors, which connects to the above 2 points, is how does the person cope with stress? What is resilience? These are complicated questions, but something to consider as we're working through the patient narrative with the patient.
So attachment is something that you talk a lot about, and I think it's something that we don't talk about at all in medical school. And so I'm going to ask you, I think it's really difficult to conceptualize. I like the way that you narrated that as the dance that the patient does with sort of every person in their life. But sometimes without a whole lot of experience with attachment, it feels like we can either say a patient has a I don't know, a good attachment style. They have parents who are there for their emotional needs. They form strong relationships. They feel psychologically safe at home. Or a bad attachment. They have parents who have a substance use disorder, which makes them unpredictable, or parents who are in some way, emotionally or physically abusive. But I don't think that you probably want in my formulation, this patient has a good and a bad attachment style. Could you give me some examples of maybe different types of attachment styles and how I might word that?
Yes, absolutely. So attachment is one lens through which we look at development of a child into a young person and an adult. Attachment is really about the first relationships that the child experiences. So secure attachment is one where the child is raised with warmth, where trust is imbued in the child. And then you have insecure attachment. And insecure attachment, there are different types of insecure attachment. There's one that is labeled as insecure anxious, insecure ambivalent. There's also disorganized attachment. And this classification, comes from the work of Bowlby and Ainsworth. And we build our understanding of the patient that we're working with on the narratives that they may have experienced as very young children.
Perfect. And probably some of that's going to go way beyond the scope of this podcast. That could be, a multiple hour lecture in and of itself. And then, of course, you talked about the coping factors. And this is things like, how does a patient cope? Some people might cope by, when they're going through a difficult time, reaching out to their support system, engaging in activities that do bring them joy, doing some sort of formal emotional processing. Things like grieving come to mind. There are certain rituals for that. Or maybe they have unhealthy coping strategies, whether it's self-harm or reaching for a substance to sort of numb that emotional pain. And those are all things that you can talk about in terms of the psychological piece of the formulation.
Yes, absolutely. And I think that's what we tap into as we work with this patient is what have they done to soothe themselves? What is their distress tolerance like? And how can we enhance that? And so reminding them sometimes of that as we work with them helps them reach out to that in their toolbox of coping skills.
And we may be seeing coping skills that the patient doesn't even see, right? So when we're going through the formulation with the patient, we may perceive something about the patient because we noted that they talked about a stressful time. They talked about how they dealt with that stressful time. And we think, wow, that's a really adaptive coping factor. But, at their worst, at our worst, we as humans don't really give ourselves a lot of credit. And so it can be difficult for us to see that, oh, when I actually do have some coping skills that I can tap into. And so that's really the benefit to going through this with the patient is you can provide some extra insight there for them.
Yes, absolutely. And Mark, you raise a really beautiful point of, holding a mirror to the patient and holding space for the patient and reframing and reflecting back to the patient their story. And that is probably one of the most important things we do. And going back to your spiritual aspect and the Creighton angle, it sort of comes back to that cura personalis, where we're really listening and putting ourselves with whole concentration into the patient's narrative.
Moving forward into the social factors, what kind of things are you including in the social part of the formulation?
So I think social stressors are enormous. We think about healthcare disparities. And today we're really questioning the impact of that on all illnesses. But when I think about social stressors, I think about money, finances, poverty, housing, occupational, relational, just the environment that this person is embedded in and how that's impacting their life and their coping.
I worked in the psych ER last night, and sometimes, especially places like that, it can feel like, we went to medical school, we learned all this medicine. And then as a psychiatrist, what we're really dealing with is social factors, capitalism, the state of healthcare in the United States. And I think it can be really helpful to go through all of those with the patient and kind of shed light on them and name them and say, look at all of these social factors that you're dealing with. And I think there's a real art in expressing that to the patient without having them feel helpless by saying, this is what you're going through. And here's what we can do. Here's what you can do to help you get through all these social factors.
Exactly. And by providing that language and using first person language with the patient, you're empowering them to understand this in a different way using the dialectic that you just did.
Mhm. Okay, so those are some examples of pieces that would fit into the bio, psycho, and social areas of our formulation. Again, that's that biopsychosocial model. What are some other areas that you think are important to think about and include in our formulation?
So when I created this template and augmented it for the residents, I've included developmental lens. And here again, we include attachment theorists, Eric Erikson and his view of psychosocial development, potentially bringing in Kohlberg and Gilligan and their moral development lens, Piaget, cognitive development lens. It doesn't have to be that we include all of this, but these are ways that we can observe how this human being came to this point of where they are. What were the influences in their life as they were growing up?
I will say that it is remarkable to me sometimes. I'll be in didactics learning about, the developmental theories. And the next day I will see a patient and I will think, oh my goodness, you are the perfect, you are the platonic form of Erickson's stages of development. It really is just amazing. And I think we don't have to wedge all of these different theorists into every case formulation we do, but you follow the patient. And I think it happened a lot more than I thought that a patient will present a story and I will think this maps directly to a certain stage of development. And I think sharing that with the patient helps them to feel like, oh, I'm not alone. I'm a human being. Human beings are built for this. I'm one of many who have come before me that are dealing with a very similar dilemma in our life. And feeling like you're not alone can be really helpful to kind of get some traction on your wheels and get moving forward.
Absolutely. And I think that when I would write up my formulation in my history, it would almost be a time for me to reflect on who this person was that I saw. And there were times that I would come up with something or realize something as I was writing this up that I didn't realize at the first encounter or with the patient that I would bring back when I saw the patient again.
Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner because this is the question bank that I use to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word bootcamp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, bootcamp. Okay, so now we've gone through biopsychosocial and developmental lenses. What are some other lenses that you think we need to make sure we look through when we're doing our formulation?
I think the cultural lens is extremely important. We have a multicultural landscape, and cultivating cultural humility is critical. The question that we ask ourselves, I think, regularly is, what are we missing? And are we missing anything because we're not tuning into the patient's culture? And what's the role of implicit bias in our assessment of the patient? What assumptions are we making? And so thinking through what is the influence of the patient's culture on the presentation, I think is extremely important. And of course, we have the DSM-5 cultural formulation interview, which is a 16-item questionnaire that really sort of taps into the definition of the problem from the cultural lens of the patient. And what are people around them thinking and discussing, and what could be the perception of the pathway to the illness, and how does culture affect coping and help seeking? So these are very, very important. And I think incorporating some of that in our understanding of the patient is important.
Certainly understanding our own limitations of understanding other cultures, involving the family where we can. So culture can affect how they cope, how they seek help, and also at times, the presentation itself. We express our distress differently depending on the culture that we're living in. And just like in the case of a patient who maybe has delirium as the result of some underlying severe medical condition, in our formulation, that's going to be a very heavily biological formulation. There are some times when you'll see a patient and the cultural piece might be the majority of your formulation. And I think it's important to have respect to that.
Exactly.
Okay, biopsychosocial, developmental, cultural. What are some other lenses that we're looking through?
So, as a child and adolescent psychiatrist that works mainly with young people, the context of the patient's life is extremely important. So, who is around the patient? Understanding the family and understanding how they communicate and how they do the dance together is also an integral part, I think, of the assessment and understanding of the patient. So, as a child and adolescent psychiatrist, we work very closely with the family system and we learn to be as well versed as possible in interventions with the family. And then how to succinctly organize, document these findings in a way that is neutral and brings things again together for the patient and helps them understand why they are where they are today, because that understanding is so important for the therapeutic alliance that then moves into how potentially successful the treatment for the patient is.
And you're frequently reminding us to think of our patients and indeed ourselves as children who have grown up. There's this sort of false line that we draw at around 18 or 19, depending on the state, where you're no longer a child and you're an adult. But the truth is that our experiences growing up, informed who we are so much. I have a lot of difficulty thinking about how I would put such a complex thing on paper. I think of things like birth order, family roles, different coalitions that are formed in the family system, the ways patients are disciplined and learn to cope within a family, the stories family tell about themselves. Could you give me an example of how I might actually concretely word that and put it into a document? Like, what kind of things am I really thinking are important enough to include in my formulation?
So, for example, Mark, if I can launch into sort of putting a biopsychosocial formulation together and add the family lens to it, I can reflect back to you a case that I worked on a few years ago when I was at the University of Tennessee in Memphis. That just comes instinctively to me because I've presented this before. So, in our child and adolescent outpatient clinic, we were working with patient NG. She was about 15. And so I usually start my formulation with a first sentence. So, for example, NG is a 15-year-old Latinx, Latina female who attends this school, lives with mom and dad, and these are her siblings, just to give a broad brush of who this patient is. Following that, I go into why they're here. So NG is here due to symptoms of irritability, oppositional defiant symptoms, as well as aggression. Biological factors that are predisposing to this include a family history of depression, as well as anxiety, distant family history of autism. Not much is known about labor and delivery. Everything seemed to be fine, so none of that has impacted the biological growth. Psychological factors for this young woman was being a Latinx girl in a predominantly African American school, navigating peer relations, navigating the fact that she was slightly different, interested in different hobbies, and couldn't communicate that very well to her groups. Her sense of self was shaken by some bullying and targeting that were happening with her peers. Social factors were rampantly problematic. The family was under a lot of financial stress and could not make it to appointments. Sometimes the food was scarce. So there were many aspects contributing to the social duress this family was embedded in. Developmentally, the salient aspects of the work that she needed to do was consolidation of her identity. Moving away from family of origin to being herself. That was being challenged by not fitting in with her peer, not getting in that peer acceptance, and feeling picked on and feeling bullied and feeling different. So that was impacting her sense of self as she was doing this important work. So then cultural factors, and this is linking back to your question. As we dived deep into this, we realized that the family that she was embedded in, mom, her enculturation into Texas, where they were from, was further advanced than father's enculturation because he was originally from Mexico. The language spoken in the home was predominantly Spanish by the father, English by the mother. The young woman struggled to speak in Spanish. The cultural expectations that the father had of the daughter was that she attends church every Sunday and dresses up in a skirt. And this was something that the patient wouldn't or couldn't reconcile to doing. And until we did the cultural formulation interview, we were not able to understand the exact trigger for the outburst. It was when we did the CFI that we understood that the trigger was this disconnect in what the father expected from the daughter. So to me, that opened up a whole world of work that could have been done with the patient and family that we had missed, just using sort of the medical model or the psychological model. So I want to underline to you, through this case, I understood the value, and I was thrilled that I traveled this journey with one of my fellows at the time. We had the privilege of presenting this case at ACAP and brainstorming about the value of this CFI. And I still, to date, want to do more work and teach this to discover depths that we may not have touched.
So in this case, you're really following the patient and you are being very humble about what we know and what we don't know. And you have a biopsychosocial formulation and you think, gosh, this just does not seem adequate to me. Either it's not explaining something or it's not giving me an avenue to actually make a change in this person's life. And so what do? We dig deeper. You know, we look through the developmental lens, the cultural lens. In this case, you formally did the cultural formulation interview. And that sort of, it sounds like, is where the magic lied in terms of helping this patient to get better.
Definitely. In this case, I think that was when we really understood why we had hit a wall and we hadn't progressed. So the other thing that we found out in the cultural formulation interview was that there was a completed suicide in the family that was not revealed to us. There's a lot of material that the family may struggle to disclose because of stigma, because of a feeling like by disclosing that, they reveal family secrets. You reference to secrets. So again, goes back to creating the therapeutic alliance and a safe space for ultimately this real work to be done.
Sometimes when we're going through how to do formulations, like in didactics, for example, we'll get an amazing amount of information from like the question stem. And I will often think, how are you ever going to learn this in the emergency room with a patient who is in crisis? But it all comes back to that therapeutic alliance and understanding who we are, what we bring into the room, being able to adjust that accordingly and to follow the patient. Okay, Dr. Ranga, I wanted to have a little bit of fun with this one. In class last year, we did a case formulation of the Joker. So I'm going to violate the Goldwater rule myself and put myself out there for our listeners. I've put together a case formulation of Daenerys Targaryen, Khaleesi from Game of Thrones. So this is a major Game of Thrones spoiler alert. If you haven't watched it by now, I recommend you stop listening to this podcast and go bury yourself in your bedroom for a couple of weeks and watch Game of Thrones. If you have, I hope you enjoyed this, and I would look forward to any feedback that you have. Okay, so in this case, we're going to pretend that Daenerys was captured by who else? Arya Stark, and she's brought into our psychiatric hospital here in Omaha, Nebraska. All right, here's what I got. In summary, Daenerys Targaryen is a 22-year-old female who presents following an episode of acute violence in the form of mass destruction via dragon attack. Predisposing factors include a family history of a primary psychotic disorder in the patient's father, with likely genetic preloading for same. Other predisposing factors include access to weapons of mass destruction without any regulation, history of emotional and physical abuse as a child, suboptimal attachment style, as well as an underlying narcissistic personality organization. Precipitating factors include an acute political crisis, as well as acute relationship stressors, and the patient has been increasingly isolative and her social support system has waned. Protective factors include the patient's access to resources, given her status as queen, relatively high level of intellectual functioning, and the patient has normal to high cognitive abilities, but does demonstrate a behavioral pattern and a thought pattern of all or nothing thinking, which can at times manifest in extreme instrumental violence, which has been particularly pronounced during these times of emotional distress. Provisional diagnosis is narcissistic personality disorder and unspecified mood disorder. Target symptoms for medication treatment include irritability and agitation. Target symptoms for psychotherapy include black and white thinking and narcissistic personality organization. Social interventions include a family meeting prior to discharge where we will complete a behavioral plan to ensure that the patient is engaging well with her support system and has close outpatient follow up. It may also be the case that the patient's recent violent behavior represents instrumental violence, which she believes to be justified given her underlying values. The patient's legal case is pending at this time. Dr. Ranga, have you seen Game of Thrones?
So actually, I have not. But I do want to tell you that the way you formulate it gives me a beautiful picture of what we're talking about. And that's exactly the purpose of a formulation. So my feedback to you is that I really felt that this patient was being put together as a puzzle in front of me, and I could see the painting. I felt like you used the 4 Ps, the 5 Ps very well. And having this formulaic approach, I think, is the beginning of us understanding how to capture the depth of the patient's story. And I like that you put in the target symptoms for medication management and psychotherapy, while it seems like it's separate and delineated. And maybe some of it all comes back together. Initially, delineating what we're doing helps us focus on what the treatment plan needs to deliver. So, in other words, I think you did a beautiful job. I felt like I understood the person that you were portraying to me. And I think what's also important in a formulation is reflecting perhaps on what are the positive prognostic factors. You did mention the protective factors. So while we paint this picture to ourselves and to the patient, showing them what will help them move forward, I think is also very important. So great job, Mark.
So maybe add some more prognostic factors at the end
Absolutely.
would be the most concrete
Absolutely.
thing. Okay. And then just for our listeners, the way to think about this in your mind, at least the way that I thought about this when I was going through it, is think about our 5 Ps: predisposing, precipitating, presenting, perpetuating, prognostic. And then almost like a table in your brain, you can think about each of these 5 columns. We have biological factors, psychological factors, social factors, developmental factors, cultural factors, as well as factors that stem from the patient's family of origin. And I think when you think about it as sort of a table like that, and you go through your 5 Ps and you try to hit these different areas in each of your 5 Ps, you're well on your way to a formulation that is going to be helpful for you to better understand how you can help the patient, helpful for the patient to have that mirror sort of held up to them, and hopefully a mirror which, when you hold it up to them, they can see themselves in a little bit more of a rosy light than when they initially came into your office. And it also is really necessary for communicating with other members of the healthcare team, whether it's the psychiatrist that comes after you, the nursing staff that's working with the patient on the inpatient unit. This is really helpful to put a comprehensive evaluation in there to make sure that everybody is on the same page. Because if I just say that Daenerys Targaryen is a narcissist, it doesn't come anywhere close to really telling you what you would need in order to understand the patient. Dr. Ranga, any final thoughts from you on case formulation or words of wisdom for our newly minted residents?
I think the most important thing as we write in the patient's chart is to be so mindful about who this is and potentially the fact that they may read it, and to be collaborative and to respect and, to be aware that this is the summary that they will carry with them. The impact of this is very important to weigh. And so that's my parting words to you, Mark, with this story.
Dr. Gonzalez on my rural month, he was talking about building a therapeutic alliance and having the patient trust you. And he talked about how in rural Nebraska, the wait times to see a psychiatrist, especially in person, can be 6 months, 12 months, even longer. And he said, by the time they get to your office, they think I'm the Pope. And so to your point, imagine the Pope labeling you like this, right? What we're doing is really sacred. It's really going to change the way somebody views themselves, the way they move throughout the world. And so we need to take that really seriously. Love that point about, the patient is going to read this. So we need to write it with that in mind and try to write it in a way that is not only helpful for us and honest, but also helpful for the patient. And that can also be a difficult dialectic to navigate. Okay, Dr. Ranga, I will see you soon. Thank you so much for coming on the podcast.
Thank you so much, Mark, for giving me the opportunity.
Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.